right. Over to you.
Hi, everyone. I'm Dr. Singh. I'm with Dr. Shah. We have to unfortunately turn off the video on our side because so that you can hear us clearly. So I'm just going to start with an introduction of hypertension. So essentially, I mean, we know this term as being high blood pressure, and what it actually means is that your blood vessels are under a constant state of raised pressure. When the blood is flowing through, the rate and volume and the pressure throughout that pipe, it's completely raised. So it's not a one-off reading of having a high blood pressure, but it's one that's consistently there. And as you can see, I've written at the bottom over there as well that this is contributed to lots of different problems, and it's a physiological response where our body is responding to changes, whether it's due to genes, lifestyle changes, or whether it's due to something like a chronic or acute condition. And there's a picture there that's showing the difference between a healthy blood vessel and one that's going under constant raised blood pressure on the right-hand side. Next slide, please. So when we talk about blood pressures, we commonly get two values. One's the top number and one's the bottom number. And what it signifies is the top number is the pressure that the blood vessels are going through once. Sorry, I can hear some noise, I think.
If everybody else can mute themselves, please. So, yeah, sorry about that.
So just to continue, so the top number is essentially, it signifies the pressure the heart is under and the blood vessels are under when the heart is contracting. And the bottom number, it signifies the pressure when the heart is relaxing. So we combine two numbers, the pressure when the heart is working hard and pressure when the heart is relaxing, to give us an overall value of blood pressure. And this is what signifies the constant state of pressure within the blood vessels. I'm sorry, there's some people are not muting. Can they please mute? Because it's
I'll just ask Yasmina if you can just mute everybody, if that's okay, as a host. Thank you. Yes, please.
Okay, so if you can see right to the right side, the left.
Yeah,
okay,
carry
I'm
on.
just going to carry on. So the left side shows, the blood pressure readings, and the right side is actually showing the two stages of when we're measuring the blood vessels. You can see the heart contracting and the heart relaxing. Next slide, please. So the reason that we take great importance in blood pressure is because it causes an array of complications if it's not well controlled. The most common ones we hear about is stroke and heart attacks, but they also cause longer term damage, and it could be due to kidney damages. It could cause visual impairments, but affecting the blood vessels of the eyes. And it can also lead patients to having heart failure without actually having a heart attack, because they're constantly overloading with pressure the activity of the heart. And this leads to the heart in being unable to contract properly, leading to heart failure. So this is in brief the biggest complications that happen with high blood pressures. Next slide, please. So I don't expect everyone to go in depth with this, but this is the guidelines that we use when we're actually looking at what high blood pressure is. And in brief, if a patient's got a blood pressure of 140/90, that's the time we start worrying that there might be a predisposition to having high blood pressure. So anytime you see the unit numbers 140 or 90, anything above, 140 or 90, that's the time we want to start considering that they might have high blood pressure. There are some subtype of patients that suffer from kidney disease or diabetes where we would like a bit of a lower blood pressure.
Yes, they're giving you the better one. I mean, to get as a holder, knows if she has to, but the ferritin levels are low. So
next slide, please.
Probably for weakness.
Are we co-host? Yasmina, are we co-host? Yeah. Okay. Thank you.
Okay, so I'm just going to carry on now with the next slide. So brilliant. So this slide actually shows the algorithm that we use as clinicians when we're treating patients. So once we've got the value of 140/90 or above, we then know what sort of management to take through. And there's lots of stepwise management, and there's a lot of room for us to actually treat clinically patients with high blood pressure. However, there are lots of other factors that we would want to consider moreover, and those are lifestyle changes. And one thing to note about this in specific, that this is the one that comes secondary after we have a true measurement of high blood pressure. And an important thing to know amongst everyone is that blood pressure is not a single reading that we do in the clinic. It's something that we can do over a couple of days, such as being home blood pressure reading, or we can also offer them services as having their blood pressure checked with a 24-hour monitor, which will give us a definitive answer as to whether they actually have a raised blood pressure or not. Next slide, please. I'll hand this over to Dr. Shoaib.
Thank you very much. I'm Dr. Shoaib. I'm one of the educational leads for the Fairlock PCN, and thank you for having us today, Yasmina and team. So coming back to blood pressure, what are the risk factors? So when we're in our clinic, it's very easy as a doctor for me, Dr. Bhatti, Dr. Singh, to talk about just what pills can we give to people, what are the best options, what is it? But maybe those 2 extra minutes to find out about the patient. What is their lifestyle like? What are they doing? What else can they do to help with blood pressure, and how the behavior has an impact on them? Some of them might be living on takeaways, and my colleague here just actually told me that, you know, the 6 grams of extra salt can help reduce 10 millimeter by mercury of blood pressure. So, and actually by reduction of even 1 kilogram of weight, can you make you come down by 2 millimeters mercury of blood pressure? So sometimes lots of things need to be put into place. I mean, what's their social situation like and everything. And that's why we've got our lovely colleague G here as well, who will be able to help us. Next slide, please. Sorry, I was trying to do it. Now, what is very important when we are working in our primary care setup, and why this cohort was designed for all of us. And it's important to code hypertension on EMIS. It's very, very important, because then a pink pop-up appears, which actually warns you, comes up as a warning sign with alerts, which is say what monitoring needs to be done. Are they under investigations? Do they need blood test? Plus, it helps with your cough as well. I know not all hypertensives have CKD, chronic kidney disease, but it's good medical practice to consider doing ACRs on these people. Next slide, please. Handing over to Dr. Singh.
So I think, I mean, we all measure blood pressures in clinics, and sometimes they come up a bit raised, sometimes they're a bit low. Whenever you see raised blood pressure, irrespective of whether they're on medication, you can always consider options such as getting them to repeat the blood pressure at home for 4 days, for twice a day for 4 days, and bring it back to speak to the doctor. You can ask them to, you can, if you're really worried, you can ask the GP to see one of the clinicians, especially if it's a very high reading. And in particular, high readings, it leads me to the first point. When you're seeing blood pressures that are reaching around 180 in the top number, and I like to use a bit of a lower aspect for the bottom number. If you see anyone with a blood pressure of 180 for the top one, or 100 for the bottom one, I would want them to be seen by a clinician just to ensure that we have got good management. Because this state of blood pressure, it's extremely high, even if it's just a sudden one, that can lead to a sudden heart attack or a stroke. So they really need to be seen or discussed on the same day. And whenever they have any symptoms that are associated with this, be it headache or visual issues or feeling really short of breath, if their blood pressure is this high, it's considered a medical emergency and they should be going straight to A&E. Now, another thing that we should be cautious about is pregnant women. If they come in with high blood pressures, please do a urine test and let one of the physicians know, because it will then help us identify whether this patient is at risk of having complications in pregnancy. And I know we've talked a lot about raised blood pressure, but you may often find yourself in situations where the blood pressure is low. It's not always alarming, especially if they've got a trend of recurrently having low blood pressures. one thing that you can do sometimes if you see someone with a low blood pressure is take a heart rate. If their heart rate is within a normal rate, being less than 100, then it's reassuring. Otherwise, there might be something else going on. And that would be the point I would say, speak to one of the clinicians. Next slide, please. So in terms of monitoring, I mean, this gets alerted up on the EMIS system. So you do it most patients get it done every year or every 3 months. It's really much personal choice with patients and also what you see on the alert flag up. We like to get a good control of blood pressure within the first 3 months of treatment. So you do good treatment and you do a good review after 3 months and see what the blood pressure is like. But patients who do have good blood pressure control consistently, you can do the blood pressure every 3 to 5 years. But there's no strict screening or guidance on monitoring. If anyone has any questions so far about anything that I've discussed, whether it's about concerns about certain blood pressures or what blood pressures to be worried about or the monitoring or anything that we've covered so far, even lifestyle change, we're more than happy to answer 1 or 2 questions before we move on.
I mean, it's a lot of clinical stuff we've thrown out at you. I mean, is there anybody that would like to ask any questions about anything? I mean, we're open to Dr. Singh, Dr. Bhatti, and myself are open to any clinical suggestions, any clinical concerns.
Feel free to use the chat as well.
Yes, we're monitoring the chat. So anybody whose mic's not working, camera's not working, use the chat. We will answer your questions on chat.
All right, next slide, please. All right, this is just something for everyone to look at. There's resources up on British Heart Foundation. It's very good and explains a lot of things. And it's very good for patients to have this resource and understanding how to monitor the blood pressure and how to actually good lifestyle prevention measures. And in addition, in Acurex's, most practices have got home BP monitoring where they send a link to patients and the patients then reply back onto it after 4 days with blood pressure readings. So I will move on to G now and Dr. Bhatti, and I will be monitoring the chat to see if anyone has questions and I'll answer back.
So I'm handing over to Dr. Bhatti. Please slide 11, please. Dr. Bhatti, over to you, please.
Hi, thank you. Thank you, everyone. Thank you, Dr. Shoaib and Dr. Singh, and thank you, Yasmina, for inviting us to our very well-attended hypertension webinar today. I'm extremely pleased to come as a dual role of me being the educational lead for our PCN and being the clinical director for our PCN as well. I think everything that's been said is just so relevant with the sort of how education and our roles are coming together. I really have found that the role is challenging in sort of bringing everything together, but our aim was to have all the PCNs to be approved as multi-professional learning environments, and I think we've been in the journey together to have this approval. I would just speak on behalf of, the care of all the long-term conditions that we have to get involved with the PCN level. And I have to say, we cannot do this without the support of our personalized care roles in primary care, all the additional roles. As you can see, we are looking at all the help coming from the health and well-being coaches, the social prescribers, and the care coordinators. And I think they are forming the bulk of our ARR teams in the PCN. A lot can be said of what we're dealing with in hypertension. As you would be aware, there are so many projects going on with health inequalities, mainly looking at optimizing care as we are at the moment, together with early detection. On the notes of early detections, we have our wonderful HCAs working at the practice level, doing all kinds of health checks, early detection, clinic checks, as well as ambulatory monitoring, and providing that bit of holistic care which the patient needs, and more so giving that bit of little extra time, as Dr. Shoaib was saying, those 2 minutes matters a lot to the patients. I think from my experience and what I have seen, the difference that the social prescribers and teams that have made in our PCN is just exemplary. Patients have been delighted to have that input, that personalized approach, and the joy that brings to them. I can just touch on a couple of events that we've had, and we have had the pleasure of all of us being together with our wonderful public health support to have the pop-up clinics for cardiovascular checks, blood pressure checks, and point of care testing for hypertension and hyperlipidemia. I could go on from my perspective, but I think I'll hand you swiftly over to Jean, who will sort of introduce all the work done in terms of the real personalized care that is being provided. As you can see, the social prescribers, you know, they cover a lot of wider determinants of health, which includes a lot of housing issues, benefits. You know, they look after people if they are having a bit of social isolation, carer support. And I've had so many examples of very, very positive feedback come, you know, from the input received by the social prescribers. The next group is the care coordinators, which I really can't say enough about. And the amount of coordination of care that they provide from the back office function is just exemplary, with all the call, recall, getting to know the patients, calling them, bringing them to the clinics, making sure they attend, and then just linking it back to the clinical teams. Health and wellbeing coaches is absolutely wonderful role to have, and I will ask G to elaborate on that. It's something that I have not had the experience of yet in our PCN, but we are waiting for the roles to join shortly. So I'll just stop there and hand you over to G. So thank you very much.
Thank you, Dr. Bharti. Hello, everyone. I am representing the personalised care workforce, health and wellbeing coaches, social prescribers and care coordinators. I've been in this role as a health and wellbeing coach across North East London and now North West London for coming up to 3 years. And what I'd like to share is some real life examples of how our workforce can add value to work streams and for workforce capacity. The most important thing about this particular slide isn't what our roles are. I think us as individuals who are already social prescribers, care coordinators and health and wellbeing coaches, we already know what a difference we're making to those patients' lives. And it's actually just transforming the conversation because we have the time to do so. It's transferring the conversation from what is the matter with you to what matters to you, and really putting that patient in their seat of power so that they can spend that time with us, really getting to the heart of what matters to them. As a health and wellbeing coach, we're expert in behavior change. Okay, what does that mean? We actually have time to listen to patients and perhaps rephrase or eloquently dig deep beneath what is concerning the patient, the other determinants of health, and help them find solutions, set some goals, and navigate the way so that they're in a better place. And actually, at the end of the day, everyone is just looking for peace of mind and happiness. Well, that's what I'm speaking from my experience. Next slide, please. So here I'm going to share some examples of early prevention and proactive care. Now, before I do so, can you please in the text box write down how many of what I'd like to engage is how many of you have been tasked or are working on hypertension work streams. So are you looking at hypertensive patients, long-term conditions? Are there any projects that you're currently involved in as a health and wellbeing coach, a social prescriber or a care coordinator? It will be really nice to see what people are doing in their individual PCNs. So this is an example from Havering North PCN where I was working. And it's just really showcasing that clinicians, health HCAs and pharmacists supported by care coordinators, when they identify newly diagnosed patients, either through health checks or the regular checks that they come in to do, and also those patients with low to moderate risks requiring lifestyle modifications. These are the kind of patients that can be referred to personalised care teams, health and wellbeing coaches or social prescribers. There's also the hypertension list, which is part of the quality outcomes framework, and also we look at Q risks, and I'll talk about Q risk later, but that's a way of measuring a risk of CVD, cardiovascular disease. So these are the type of patients that can be referred to health and wellbeing coaches and social prescribers, who will then get under the skin, beneath the problem, and look at diet, exercise, lifestyle education, and other determinants of health, and engage with voluntary and community services. Next slide, please. So this project was in 2021-22. It's part of the UCLP long-term conditions frameworks, and it was to deliver proactive primary prevention to cardiovascular disease risk groups. It's a long title, but in actual fact, what we were doing was looking at patients who appeared in with a Q risk of 10%, and what that meant was it was an estimate of patients developing cardiovascular disease in about 10 years, and then providing lifestyle intervention. So the more risk factors a patient has, it could be AF, hypertension, cholesterol, type 2 diabetes, the greater the risk of developing heart disease. And we're all familiar with these terms. I think clinicians are really work towards the disease, whereas for personalised care roles, we get underneath their disease. So it doesn't really matter what disease a patient has or what label they've come with, we're going to be getting underneath. Next slide, please. For this particular project, we used the NICE recommendations. How many of you are aware of the NICE recommendations? How many of you refer to them? It'll be really good to gauge an understanding. If you do, please put it in the text box. So we followed the NICE recommendations. So here it states that any person with CVD risk assessment should be given lifestyle advice regardless of the risk score. And that should be about smoking cessation, weight loss, eating healthy, alcohol consumption, and being physically active. And actually common sense prevails here. How can someone who's smoking, sedentary, not eating healthy, how can they have a healthy lifestyle? So actually everything works together. Next slide, please. So this slide is looking at the dimensions of our well-being, a person's well-being, and really how an MDT approach for the ARR roles is vital, really. As a health and wellbeing coach, I work really closely with my social prescribers and the care coordinators, occupational therapists, pharmacists, and my GP colleagues as well. And like I've said before, the needs assessment is about what matters to me. It gets beneath the symptoms that are presenting and identifies their health goals alongside a realistic timeline. Now, I will perhaps see a patient for 6 sessions, and that could be over a matter of 3 months, but I have much longer to spend with them, anything up to an hour. And I know social prescribers will work between 30 minutes to an hour, depending on how much time that patient needs over a period of time. Social prescribers generally signpost and connect the patient to community, whatever resources they require. That could be housing, financial assistance, it could be to do with isolation, it could just be transportation, but really it's getting to the, underneath to what that patient needs to improve their well-being. Health wellbeing coaches, we look at empowerment. So it's about lifestyle education, diet and activity. Not that I would give dietary advice. I am a nutritionist, so maybe top line advice, but I would definitely recommend and signpost to some of the NHS advisory lines, for example, NDPP, or any local services that we might have. And it's all about supporting a patient's self-management, motivating them, transforming the way that they actually see things. And sometimes I often use a lot of techniques to help them step out of their stress, because most patients are quite stressed with where they are with their health condition. And that could be with a variety of techniques. And I've met many of you, and I know we have a highly skilled workforce between the ARR group. I also work closely with the MDT, so OT, pharmacists, physios, and mental health practitioners. And the most important thing is connecting everyone. So being this bridge between the voluntary sector and the clinical sector. The other thing that's really important for our roles to understand is the coding, SNOMED codes. How many of you use provision of proactive care? I know most of us use seen by, so it's seen by a health and wellbeing coach, seen by a care coordinator, or referred to a social prescriber, but what other codes are you instructed to use? Next slide, please. So the outcome of the hypertension project that I was involved with after 4 months is quite visible here, and this is from Havering North. It was a multi-professional team. It was the health and wellbeing coaches, care coordinators. We worked with HCAs and the clinical pharmacists, as well as clinicians. But you can see out of a general population, 2,440 blood pressure readings were taken, and that was actually because care coordination was involved to ensure that BP monitors were distributed and we collated up-to-date readings, which enabled clinical pharmacists and healthcare associates to do their NHS checks. Lifestyle interventions, we had over 1,000 lifestyle interventions for these newly diagnosed patients. Medication reviews were done by clinical pharmacists, but NDPP, pre-diabetes, smoking cessation, and weight management, this was all project managed and led by the ARR team. And actually it helped PCN achieve their QOF for the year and achieve their IIF targets. We also identified an unmet need, which was that we needed a local smoking cessation service, which wasn't present, and public health managed to secure some funding for that. So here's a perfect example of how we can make a difference. Next slide, please. So I'm just going to share a couple of success stories. The first one, so these are real life cases. Sue, 78, she was referred via Joy. I'm sure we're all familiar with the Joy referral system. The notes that we received was that she was recently diagnosed with elevated blood pressure and cholesterol. She was reluctant to take medication due to her sensitivity. She'd agreed to try a type of statin every other day, which she had started a week ago and was under HCA supervision and monitoring. And she was referred to myself for lifestyle support. Now, in my initial assessment in 60 minutes, she was really concerned about her health, quite worried when she came in. She said that she didn't understand why she had high blood pressure because her and her husband had led a proactive lifestyle to keep her heart healthy for so long. She really looked amazing for a 78-year-old, but I could see that there was concern on her face, and she was really unsure about the recent tests. And she shared her good diet with me. So I asked her what had changed recently. And she said her husband had fallen ill that year, and she'd started caring for him. So his health has deteriorated, and both of them were unable to participate in the activities that they had enjoyed. So their physical activities had declined. And she was carrying the extra responsibility, feeling stressed, unable to cope. Her family lived far away, so she didn't have any immediate help close by. And she'd started drinking wine to relax, as most of us do. She wasn't digitally connected, so she didn't have a mobile phone. She didn't know how to use the internet to access any services and felt quite isolated. The support I've already mentioned, children lived away, and she had some friends, but they were all too busy. So I asked her what it would take, what was what concerns her the most right now, and what would it take to restore the balance? And she said it would really be beneficial to access winter activities where both of them, her husband and herself, could join together. She asked about transportation. She wasn't aware that she could access it or how she could. She wasn't worried. She wasn't too worried about finances. They were quite well off, and she wanted some extra dietary tips and advice. So I'm going to ask you, the audience, in this case, just perhaps soundboard what would be the way that you would deal with this particular patient. What do you think are the 3 things that you could advocate or suggest or direct the patient to? Do you want to just put some ideas into the text? Any ideas? Anyone? Got about 30 seconds. There's no right or wrong to this. Link with Age UK, perfect. Thank you, Raquel. Mary, refer to social prescriber. Yep, absolutely. Age UK, support with transport, dial a ride. Perfect. Link to local exercise groups, social groups. Yep. Just bearing in mind that her husband has got a long-term condition and his health deteriorated, so he can't access the normal exercise groups. So there are some long-term conditions that we need to be aware of. Chair yoga, yeah, perfect. Any chair-based exercises, brilliant. Maybe creative for life, yep, creative arts, coffee sessions, perfect. Excellent. Next slide, please. So what did we do? So the coaching outcomes and the actions. Thank you, everyone, for sharing. That's brilliant. A signposted to a social prescriber. Perfect. So someone's already mentioned that for local activities, the local churches and the community centre, which were able to sort out transportation. We also had an OT assessment for her husband at home, just to alleviate her worries. And there was a brilliant digital education programme for those elderly folk or people who weren't digitally clued up. So there were a series of 8 sessions that we sent them both to, actually. First 2 were face-to-face, and then after that they could access it online. So their children had bought them a little digital iPad. So it's really transformed their lives. It's amazing what things, small differences can make. I talked through the stress management. So I gave us some stress management on education via the stress management organisation online. It's a brilliant service and organisation. If you haven't accessed it, I highly encourage you all to do so. And really talked about the impact of stress and its symptoms, and helped her understand her triggers and the impact of health. And really, it's common sense again. When we're under stress, when things change, our BP will raise. The danger becomes when that blood pressure remains elevated for a length of time. Hence, we check the blood pressure over a period of time. But generally, when it's short phase stress, it's really easy to get back to our baseline by using some of the natural techniques. And I taught her a really simple technique called bellows breath, which is very simple to do. And she ended up laughing as a result. How many of you are familiar or use bellows breath with your patients? Anyone? We can all do it now. It'll only take 60 seconds. If you're sitting calm and if you're sitting comfortably in your seat, make sure your feet are on the floor, flat on the floor. And what I generally ask is, ask the patient, or I'll ask you just to roll your shoulders back and allow your arms to hang by the sides. On an in-breath, we're going to raise our hands above our head. And as we do so, we're going to breathe in. So taking a deep breath in. And on an exhale, we're going to drop our elbows into our side ribs and shout, ha! Got it? So again, breathing in on an in-breath, raising the arms above our heads. Exhale, ha! And we do that about 3 or 4 times. The first thing that happens is that you get a tingling sensation. And really what we're doing is we're giving this stress somewhere to go. So this is the classic fight or flight response. When we're stressed, we either want to beat something or someone up, or we want to run for our lives. But instead, we end up internalizing it, hence impacting our BP, cholesterol, etc. So early diagnosis, it's really, really impactful to use these simple techniques to help disperse the stress. And it's so simple to do, she couldn't believe it. And it completely changed the energy on her face. So the patient felt relieved after the first session. She was supported and empowered. Within 2 weeks, she started activities with her husband, connected via the social prescriber. Within week 6, she had developed a care plan with her family to support her husband and also relieve herself of that added extra stress. So she was able to share the load. And in a few months, health and happiness was restored. So the total sessions were 6, approximately 8 hours of work. Next slide, please. And I'm sure we've all had outcomes like this. Success story number 2, case 2, middle-aged female, multiple health conditions, elevated BP. She was actually referred due to workplace stress, and she was on 13 different medications, which also was causing stress. The initial assessment for 60 minutes, again, she was a CEO of a company. There were 2 CEOs, and she felt like she was carrying the burden of the company. She had no time, fast food, lack of sleep, constantly on the go, forgetful about taking meds, when to take them, you know, how should I take them, sometimes with Coke, sometimes with wine. So not really adhering to what she should be doing. 4 children, 1 autistic child, which was very challenging. She was unable to cope really, and she'd had a divorce a couple of years ago, and she didn't feel she had a supportive structure. What mattered to her, she wanted a better work-life balance, wanted to feel more energetic and supported and present for her family. So in this case, what would you do? Just throw something in the group chat. What are the kind of things that you would do? We've got about a minute. Anyone? Refer to a social prescriber for local activities. Oh no, sorry. Refer to a social prescriber. Yeah. Pharmacist. Brilliant. And stress management. Yes. Pharmacist. Why? Polypharmacy. That's the first thing I did. I thought, my God, 13 medications. And 4 of them were just for one condition, her blood pressure. Obviously, it wasn't working for her, and she was really stressed about when to take what. So I referred her to the pharmacist for a medication review. Medication review and compliance, concordance, yes, perfect. Refer to RAGS, perfect. Sycamore Trust for support with children, yeah, wonderful. Support with child, yeah, fantastic. Thank you, Janaki. Next slide, please. Brilliant, brilliant response. So here, medication reviews, the first thing I referred her to, the clinical pharmacist, reduced her polypharmacy to 7 based on lifestyle state changes that she promised to make, and also the smoking cessation service. So she was a heavy smoker. Work-life balance, we delegated responsibility. So she recruited more staff for mundane tasks, which created more time for her to do the more important things for her life. For her child, she introduced a pet, started visiting farms, which really changed the child's mood and connection and her behaviour, and referred her to some local autism groups. So I'd created a group organically because I ended up with quite a lot of mothers with autistic children and connected them with SENS nurses as well. So it's amazing what happens when you connect people and the support they feel. Stress management, learning her triggers and useful techniques. We introduced workplace exercises, the things like desk-a-size, the gym, walking, and she introduced wellbeing at work. And she also requested to see a mental health practitioner for her mental health support as well. So CBT, which she decided to go for privately. So really, it took 4 months for her to change her life. She felt supported. She could soundboard without being judged. She could just be herself. She gained clarity and she managed to achieve her goal. She was quite goal-driven and target-driven anyway. So she just needed a blank canvas to put on that piece of paper what was important to her and what she could let go of. It really made a positive impact, not only on her health, but on her children as well. And that was a total of 8 sessions. I'm sure many of you have got case studies that you would like to share with us. I'd like to actually delve in to see what kind of cases you are working on too. This brings us to the end of our hypertension slides, and I'm going to hand over for questions. I hope you found that informative, for some reflective work as well. Please do share your experiences in the chat. Dr. Barty?
Hello there. Yes, thank you, Jude. Thank you so much for taking us through to the delivery of the proactive roles. As you mentioned, it's absolutely wonderful to see the beautiful work done. I think I can go on and really share a lot of positive outcomes of patients that I've seen, but I think if I just open it up for people, if they have any questions or maybe feedback or comments, and I think we have Raquel here, who's our social prescriber. Raquel, do you mind if you just share a little bit of your views on the work done at the PCN? Thank you.
Hi everyone, lovely session. Let me say that it's been really interesting, really informative. So good to see what is happening across the patch and the different patches. I guess this is a very big patch, right, in Northeast London. So I guess that we have been working precisely in health inequalities and trying to reach those hard to connect with, the ones that might not come organically to primary care, and really offer a variety of sessions and support that wasn't available really. So we partnered with a local CIC, working with this cohort of patients, and we have applied for different streams of funding, first with the Northeast London Health Inequalities, the community chest, and then with the ICB. So we are in our second phase now. The first phase was wonderful. We reached over 90 women, and we had 180 visits to the hub that ended up in a lovely celebration at the local library. And we started again in September. We are about to deliver session 5 tomorrow at the local library, and it is about stress management. Funny enough now that you were mentioning that. So it's really wonderful to get to see all of these patients that you normally speak to on the phone and finally meeting you, especially at the pop-up event with public health last week as well. It was really good to see all the patients coming through and making use of everything and everyone that was there. So yeah, I guess that's what I wanted to share. But we are looking forward to sort of work in more projects, bring other specialists, and really reaching out those that are most vulnerable, I guess. So yeah, that's from me.
Thank you, Raquel. Thank you so much for bringing your views. And this is what we want to be sort of together at the training hub, to bring the multi-professional learning together, learning from experience, learning to see how everyone is doing so well in their patches, and really make it known for good practice. So I think, G, would you like to come in?
Yeah, I was just going to say, I've just looked back at the chat, and Janaki said that she's working as a PCN pharmacy technician, brilliant, on high risk drug monitoring. That's brilliant. Do you work with your, your ARRs, so health and wellbeing coaches? Do you interact with them? Do you work with them for lifestyle interventions, things like that? That'd be really good to know. Mary Gray said that she's supporting a surgery to contact patients for BP data and booking for health checks. If anyone would like any information on how to develop pathways, so how to get involved with these crucial work streams, because clinicians are working on them as part of the QOF, IIF, please do reach out. I'm happy to mentor or help, assist, bridge that gap so that, health coaches, social prescribers can really get involved in making a difference and collating the information as well.
Thank you, G.
Thank you very much, everybody, for participating in everything today. What we would like is Yasmina, Dr. Singh, Dr. Bhatti, along with me, we worked very hard to try and get this session to work. If everybody could take just a couple of minutes while we open questions to the floor to fill out the feedback form in the chat, it would give us an idea on how to plan future sessions, and we can address other learning needs, because you are our staff, you are our people, you are our team. You're actually the future of general practice, and whatever we can do to help and support you, we're there for you, basically. So unless we don't know what to change, we won't know what to change or how to change, we won't be able to do it. But thank you so much.
And I also want to say a special thanks to G, because she ensured that we tailored this to your cohort, and also made sure that she involved a lot of information. As you can see, she's put a lot of work into the slides in tailoring it to the tier 1 cohort. So thank you very much. And thank you everyone for participating as much as you could.
And thank you, Yasmina, for keeping all of us together. Despite your nice and calm face, you've still managed to get the tech to work, which is my nightmare. And Dr. Bhatti, thank you so much for supporting us on the role. And G, I can see that, you know what, you've made this session a complete success. Thank you, team. Thank you so much. Any questions? It's open to the floor. Okay. Yep. Thank you. So if you wouldn't mind, just before leaving, doing the feedback for us, it would be really helpful. It's pasted in the chat link.
They definitely got it. I saw it as well.
You saw it.
Yasmina, do you know how many, sorry, I was going to
Sorry,
ask, do you know how many health coaches or social prescribers were present?
Yes, there were a number of questions before they registered, clicked and registered. So I'll let you know.
That's great.
Hi, sorry, I think the form wasn't going through for me.
So the form I'm sending, I'm copying, pasting it again, the form.
All right.
Has it gone through now? If
Yeah.
you look at the chat.
Thanks.
It'll just help us plan and address the learning needs of our workforce. But thank you everybody for coming. Any questions for us? You can actually see us now, which might just make things a bit more personal, but anything, we're there. If there are any questions that crop up, you can always email them to Yasmina, and she can send them our way. And we're more than happy to help and support in any way possible with the help of the Training Hub. and within our roles and remit. Dr. Bharti, anything from you?
No, it's been wonderful. I think this is the challenge which we faced in terms of pitching at multi-professional level. But I think we've learned it, and we want to get it right for our different cohort of learners that come. And we would really welcome people to join, to come with ideas, and to make it happen and work together. It's really a pleasure to be here and working with the team. Thank you, Dr. Shoaib. Thank you, Dr. Singh, and Yasmin, for arranging all of this.
No, I think it was a really good one. And I think most of us are meeting tomorrow as well, right?
For the CKD.
Yeah, I won't be there for the CKD
Yasmin,
one. I have to speak to Fazana.
Yeah, we're sad to hear that. It would have been very good to have you there. Yasmin, with the slides for the one tomorrow, they're mainly pictures. We actually need to play it in the slideshow mode, not just keep it into the.
So I wanted to ask you that earlier. Let me just stop the recording. Do we have any more questions?
No.
Okay, let me stop the recording.
I was going to say one more thing, Yasmina. You know this, the link that we've sent today,